Hello and welcome. My name is Valerie Newitt, and I'd like to welcome you to the webinar, Diagnosis and Management of Sepsis, the Value of Biomarkers and Rapid Microbiology, sponsored by Biomarkers and presented by Dr. Robert A. Balk. And now I would like to introduce our presenter, Dr. Robert A. Balk, the J. Bailey Center, MD Professor of Internal Medicine at Rush Medical College. Dr. Balk went to the University of Missouri at Kansas City's six-year medical school and received his BA in biology in 1976 and the MD degree in 1978. He completed his internship and residency in internal medicine at the University of Missouri, Kansas City, and went to the University of Arkansas for medical sciences for fellowship training in pulmonary and critical care medicine. After spending 1.5 years on the teaching faculty of the University of Arkansas for medical sciences, Dr. Balk moved to Chicago to join the section of pulmonary and critical care medicine at Rush University Medical Center and Rush Medical College. Currently, Dr. Balk is the J. Bailey Carter, MD, Professor of Medicine at Rush Medical College and Director of the Division of Pulmonary and Critical Care Medicine at Rush University Medical Center in Chicago, Illinois. He's also the Director of the Adult Cystic Fibrosis Program and the Medical Director of the Pulmonary Rehabilitation Program at Rush Oak Park Hospital. At this point, it is my great pleasure to turn the presentation over to Dr. Balk.
Thank you, Valerie. This afternoon, I'd like to spend a little bit of your time to talk about the diagnosis and management of sepsis and talk about the value of biomarkers and some of the new rapid microbiologic techniques that are available to help us. I do have to upfront tell you that I have received honoraria, research support, and consulting fees from Brahms, Thermo Fisher, and Biomarkers, both of which are involved in Procalcitonin monitoring. And without further ado, let me move into a discussion of severe sepsis and septic shock, which fortunately over the last couple of years has now become the 11th most common cause of death in the United States instead of being the 10th most common cause of death. But remember, for a lot of you who take care of patients with pneumonia and other respiratory issues, pneumonia and respiratory infections are actually the 7th most common cause of death. So I would think most people who die of pneumonia probably have sepsis, and probably if we reclassified this, sepsis and septic shock would be even more prevalent than the 7th or 11th most common cause of death. Looking at some studies using ICD-9 codes of patients who had both severe infection and had an organ dysfunction, back in 1995, it was postulated that there were 751,000 episodes of severe sepsis in the United States, and with an annual increase of 1.5% per year, by 2010, we were going to be approaching 1 million episodes of sepsis, severe sepsis, septic shock each year in the United States. And the very bothersome point of this all is that we still have an excessively high mortality rate despite our increased awareness, our use of better guidelines and bundles of care, better, improved antibiotic therapy, and improved technology. You can see from this slide from Derek Angus and his co-workers that sepsis is predominantly a disease that affects those who are very young, and as you hit age 50, you can see an almost exponential rise in the incidence of sepsis and the number of cases of sepsis each year in the United States. So we have a lot of challenges. We are still looking for some way to have early recognition and enhance our diagnosis. We'd like to be able to know what is the cause of sepsis so we can give more optimal therapy and maybe come up with a magic silver or gold bullet vis-a-vis the Lone Ranger that would take care of improving sepsis outcome. And we have a terrific economic and societal impact of severe sepsis that we'll review towards the end of this presentation. What I would like to do in the next 40 or 45 minutes is go over how to diagnose severe sepsis and septic shock and where procalcitonin may come in handy in that regard. discuss the possible use of procalcitonin and rapid infection detection assays to help us improve our treatment decision and as well as our detection, discuss the role of procalcitonin in the prognosis of patients with severe sepsis and septic shock, and talk about a combined role of procalcitonin rapid detection strategies to maybe improve antibiotic stewardship and maybe minimize our risk for having these resistant bacteria, which we are all going to deal with over the next few years. Let's start with what are biomarkers. Biomarkers are characteristics that can be objectively measured and evaluated as an indicator of either a normal biological process, a pathogenic biological process, or a pharmacologic response to some sort of therapeutic intervention. They're useful when they're able to be obtained in a very rapid, accurate fashion, and when they have a lot of sensitivity and a high amount of specificity. Biomarkers can help us identify patients with an increased probability of a disease or an adverse outcome, or identify people who might benefit from a specific intervention. They can identify the presence or absence of a pathologic state or process and aid in risk stratification and prognostic determination. They can also be used to monitor a response to an intervention or treatment, and for those who are involved in research studies, they may serve as surrogate endpoints to help validate the usefulness of a new drug or technique. We commonly use a variety of biomarkers in everyday practice. We're all very familiar with the value of a D-dimer in determining who may or may not have a DVT or pulmonary embolus. We use BNP to help us assess patients for heart failure. Troponins are used to detect patients with myocardial infarction. Rheumatoid factor for rheumatoid arthritis. We use the cortisol response to an ACTH stimulation test to look for patients with adrenal insufficiency. Any of you who work with cancer know that there are a whole host of biomarkers that now dictate not only the diagnosis of cancer, but how to manage the patient with cancer. And for our patients in shock, we've been using lactate as a measure of determining not only the altered metabolism, but to help us determine when the patients are ready for being improved or lessening their therapy. If you look at this dynamic, changing landscape of sepsis biomarkers, here's a study that looked at over 3,370 references in 2009, and they identified 178 distinct biomarkers that could be used to find the presence or absence of sepsis, differentiate bacterial from non-bacterial infection, help with triage decisions, help guide the need and duration of antibiotic therapy, predict complications such as organ failure or multiple organ dysfunction syndrome, to give us a clue as to the prognosis, and identify patients who may benefit from specific therapy. Some of these biomarkers that have been utilized include cytokines, chemokines, various cell surface markers, various receptor biomarkers, action of the coagulation system, biomarkers of vascular endothelial cell damage or of vasodilatation. As we've already mentioned, organ dysfunction, certain acute phase proteins, and other miscellaneous markers. And these are just a few of those biomarkers that have been evaluated. And you can see we look at microbial products, physiologic parameters, hematopoietic cells, cell surface markers, soluble receptors, a variety of different cytokines, acute phase reactants, mediators of coagulation, and a whole host of miscellaneous biomarkers. When we talk about sepsis, sepsis currently is diagnosed using clinical definitions combined with culture results. Many of you may remember that back in 1991, there was a consensus conference with members of the American College of Chest Physicians and the Society of Critical Care Medicine that looked at sepsis as a inflammatory response that seemed to be a systemic inflammatory response related to the presence of an actual infection. And when you have an organ dysfunction, then you are talking about severe sepsis. We have to differentiate the fact that there are a whole host of other conditions, from pancreatitis, trauma, burns, other insults, that can lead to a similar systemic inflammatory response syndrome, but not necessarily related to infection, and those have been termed SIRS. With this consensus conference, it became clear that there would be an insult, and a variety of bacterial, viral, fungal, parasites, infection, or even trauma can put together a systemic inflammatory response syndrome, clinically manifest as having an alteration in body temperature, either fever or hypothermia, an elevated heart rate, elevated respiratory rate, or evidence of hyperventilation, or having either an elevated white count, a low white count, or a lot of immature band forms. And when you have two or more of these four criteria, then you have met the criteria for a systemic inflammatory response syndrome. If that response is secondary to a documented infection, we would term that sepsis. But in the ICU, patients typically have at least one acute organ dysfunction referable to this inflammatory process, and we would term that severe sepsis. And of course, if there's evidence of shock, we call that sepsis shock. And if we have organ dysfunction, you would call that septic shock with organ dysfunction. There's a whole host of potential diagnostic strategies to help improve our ability to recognize the patient with severe sepsis and septic shock. One of those was the second International Consensus Conference definition, reaffirmed the SIRS concept and sepsis concept, but expanded it with other modalities to help improve recognition. Some have advocated for the use of cytokine and endotoxin assays, and there is a bedside endotoxin assay. There is a bedside interleukin-6 assay. Some have looked at procalcitonin, CRP, N-terminal proBNP, pronadrenal have all been evaluated as to their ability to help find the patient with sepsis as early as possible so you can intervene as early as possible. We've talked about the endotoxin determination, lipopolysaccharide, other cytokines. We actually worked early on in putting together an endotoxin cytokine score to help identify patients with sepsis. And some have looked at various cytokines or abnormalities of toll-like receptor 4 or the cell surface CD14 receptor in order to highlight patients who may have sepsis. Looking specifically at tumor necrosis factor, here is a search of 1,935 articles looking at tumor necrosis factor number 2 as a way to predict patients with an increased likelihood of sepsis or an increased mortality for sepsis. They found that 25 of these articles were adequate to go through a meta-analysis, and they found that the use of an elevated TNF2 was associated with an increased sepsis risk with an odd ratio of 2.15. However, the strongest association was found in the Asian population, but there was no association between TNF2 and mortality. So still striving to find that universal marker. Looking at prohormones of calcitonin, which is a biomarker associated with bacterial infection that may have applicability in the early diagnosis of sepsis or to help us with triage or prognostic decisions, we're going to talk a little bit about that biomarker, which is procalcitonin. And you can see here's a structure of procalcitonin. Normally, most of the procalcitonin is coming from the lung and the thyroid gland, but in the septic patients, you can see procalcitonin can come from a variety of tissues and seems to be an indicator of bacterial infection. Healthy individuals have a very low procalcitonin concentration in their blood, But with the onset of infection and then systemic infection to severe sepsis to septic shock, you can see a dramatic increase in the level of procalcitonin. If you look at procalcitonin as a way to differentiate SIRS from sepsis, so we're trying to identify those patients with an actual infection causing the SIRS response. Here we see the receiver operating curve, and we have a mean sensitivity of 0.77, a mean specificity of 0.79, and an area under the ROC curve of 0.85. And typically, any assay that has an area under the ROC curve greater than 0.7 has clinical usefulness. So the conclusion here is that procalcitonin may be helpful in figuring out who has sepsis, but we need to also factor in the medical history, physical exam, and clinical data. Here's another prospective observational trial in 120 consecutive non-trauma adult patients, showing that as you move from no infection to SIRS to sepsis and then to septic shock, procalcitonin levels elevate, just as in that past study. And here again, if you're trying to identify a patient with a bacterial infection versus a viral infection, recognition that the viral infections often are associated with interferon gamma release, which blocks the activation of procalcitonin. So in a bacterial infection, we expect to have higher levels of procalcitonin than in a viral infection. Looking at the time course of release of a variety of these mediators or inflammatory molecules after a bacterial challenge, you see that early on you have rises of IL-6, IL-10, and TNF, and maybe part of the reason that the attempts to neutralize these mediators by giving TNF blockers or IL-6 blockers didn't end up to be successful was that they came and went very quickly. Procalcitonin seems to have a favorable time course in that it seems to peak at about 10 to 12 to 24 hours. So it's around when clinically you're recognizing the patient with sepsis, and you can then follow its course to help you know that patients seem to be on the correct treatment. So looking at a nomogram of procalcitonin levels, if the level is less than 0.05, typically that's a normal patient without any SIRS. A level that's low, less than 0.5 nanograms per mil, may have a minor or local inflammation infection, but typically not SIRS. As you get to levels of 0.5 up to 2 nanograms per mil, sepsis is possible, infection is possible. Usually you'd follow this up with serial procalcitonin levels to see whether it's trending up or down. And when you're in a level above 2, and certainly when you get above 10 nanograms per mil, you're in a high risk for having sepsis and for developing organ dysfunction, and particularly as the level rises higher. The current FDA claim with the Vitus Brahms procalcitonin determination of human procalcitonin in human serum or plasma using the enzyme-linked fluorescent assay technique is it is used in conjunction with other laboratory findings, clinical assessments to aid in the risk assessment of critically ill patients on their first day of ICU admission for progression to severe sepsis and septic shock. As we talk about using procalcitonin, there are certain aspects of its variability that I think are important to bring out. In this French study, looking at 143 septic shock and SIRS patients in a French ICU, you can readily see that medical patients tend to have lower procalcitonin levels than surgical patients. And we know that surgery and trauma may elevate procalcitonin. But higher procalcitonin levels are associated with non-survival. Here we see various potential biomarkers, the procalcitonin seems to have a better receiver operating characteristic curve than C-reactive protein as compared to interleukin-6 and compared to lactate as far as being able to predict the severity of sepsis. In patients with trauma, especially if they have an initial procalcitonin level that's elevated that then comes down, if they then have a second rise in procalcitonin, we should think about this as marking a possible septic complication during the systemic inflammatory response syndrome after major trauma, and get you to at least focus on looking for patients who may have an underlying area of infection leading to sepsis. Now, when we combine procalcitonin with clinical assessments, you can see the receiver operating characteristic curve is much improved as to just using clinical model without procalcitonin. And here it moves the area under the curve from 0.77 to 0.94, again adding to its clinical applicability. Another area where procalcitonin may be of use is in helping to make decisions in patients with community-acquired pneumonia. There's a lot of data now suggesting that if you make your triage decision incorrectly and put a patient who should be on the ICU on the ward, that they end up having a higher mortality rate. So having a elevated procalcitonin goes along with having more of the minor criteria of pneumonia severity. Having a higher procalcitonin is usually what you see in your ICU population, and higher procalcitonins help differentiate the ward patient from an ICU patient, and delayed ICU transfer is associated with increased mortality, even higher than direct ICU admission for a patient with community-acquired pneumonia. So as we look at our patient with sepsis, one of our major goals is to start early directed antibiotic therapy. We know we have time constraints. We know we need to start with broad spectrum therapy based on where we think the infection is, what the likely organism is, and know our local antibiogram so we know what kind of resistance and other patterns we need to take into effect. We want to get our cultures back to confirm the infection, get the sensitivity back to help us tailor the antibiotic, and as the patients improve, we then will attempt to de-escalate therapy so that we demonstrate good antibiotic stewardship. We can use a variety of tests to help us with early identification of infection, and we're going to talk a little bit about things like urinary antigens, PNA FISH, and PCR technology. We know that the clock is ticking. Once a patient manifests severe sepsis or septic shock, we need to identify what we want to treat, with what we want to treat, and get the antibiotics in as soon as possible. This is data from a large study at 14 ICUs looking at the time of initiation of antibiotic therapy in relationship to the onset of hypotension. And you can see from this graphic that a number of people had a delay in starting antibiotics from the onset of hypotension, which increased their odds of death. In fact, for every hour delay, there was a 7.6% increase in mortality. And we're talking about administration of antibiotics. We're not talking about ordering antibiotics. So if the antibiotics were administered within 30 minutes after the onset of hypotension, survival of severe sepsis was 82.7%. On the other hand, if the antibiotics were administered 6 hours later, survival was only 42%. And unfortunately, that scenario happened 51.4% of the time, that the antibiotics weren't administered within the 6 hours. So we have the golden hour of sepsis management. We have our stopwatch. We are waiting to start our broad-spectrum antibiotics. seconds, minutes, hours count. We want to start as soon as feasible. In fact, we don't even want to delay getting the antibiotics in if we're having trouble getting cultures. We'd rather get the antibiotics and get the cultures as soon as feasible. We want to do other aspects of source control, removing infected catheters, lines, etc., or IND and abscess. We want to debride infected tissue, and we want to use our resuscitative efforts. Turns out that if we guess wrong and give inappropriate antibiotics to start, doesn't matter if we look at culture positive, culture negative, bacteremic or non-bacteremic patients, whether they acquired their infection in the community or in the hospital, that inappropriate antibiotics are associated with decreased survival compared to giving the correct antibiotic. Same thing based on site of infection, whether it's a pneumonia, skin and soft tissue, urinary tract, intra-abdominal, whether it's gram-positive, gram-negative, anaerobes, or yeast, delay in giving the appropriate antibiotics is associated with decreased survival. So now that we have our task ahead of us, we'd like to see where we are with prognosis and help us look at other biomarkers that may help us know that we're on the right track. This is some data we put together looking at the combination of endotoxin, lipopolysaccharide, plus IL-6, IL-1, and TNF. If the higher the amount of score, the higher the mortality. So a prognostic indicator. People have looked at lactate, and this is one I throw in here because in 2009, we concluded that blood lactate may be helpful in risk stratification, but was uncertain whether it was useful as a routine monitor of a resuscitation endpoint to demonstrate improved outcome. Subsequently, we have a number of studies that go back to observations from earlier that show that patients who maintain high lactates tend not to survive as opposed to patients whose lactate clearance takes place over the course of time. You don't have to be hypotensive or in shock to have lactate potentially offer value. Here we see in an ER study, non-shock patients with high lactates have high mortality. Low lactates do better. And of course, in shock patients, we usually ascribe high lactates to poor outcome. But what may be most important is whether or not you can decrease the lactate by 10% or more each hour or two as you give your resuscitation protocol. Here you see with lactate clearance, much better survival than those patients who are unable to clear lactate over the initial resuscitation period. Here's a second study showing that lactate clearance is associated with better outcome than the control population, and that's improved in-hospital 28-day and ICU mortality, as well as decreased organ dysfunction. Here we see that there are other biomarkers that can be used for community-acquired pneumonia. Here's mid-regional proadrenomodulin and procalcitonin, both improving our ability to predict mortality in patients with severe community-acquired pneumonia. Here we get the value of a low or decreasing procalcitonin level over time as opposed to a patient who has an increasing procalcitonin. You see a much worse outcome and a higher mortality rate compared to those patients who are demonstrating improvement in their sepsis as manifested by a decreased procalcitonin level over time. Here are ventilated patients in the ICU with pneumonia and looking at the value, whether they're community-acquired, hospital-acquired, or ventilator-associated pneumonia, higher procalcitonin levels associated with higher mortality. And looking at day 0 versus day 4, as procalcitonin levels are low, better survival compared to higher procalcitonins in those who are not going to survive. And the procalcitonin also seems to elevate as you get more evidence of organ failure, as manifested by the SOFA, Sepsis Organ Failure Assessment Score. Now we're going to spend a few minutes talking about rapid diagnosis or confirmation of sepsis. We have a burgeoning problem of more and more bacteria that are becoming resistant to common antibiotics. This is a headline from India Today. I saw a year ago when I was in India. Is your antibiotic sick? Well, all of our antibiotics are in danger of becoming of limited use as our bacteria become smarter and smarter. So we have a dilemma. We want to start initial antibiotic treatment as fast, as broad, and as quickly as possible, and using guidelines, antibiograms, our site-specific issues. We don't want to delay the administration, but we want to ensure we're giving the correct antibiotic. So we can use urinary antigens to help us for Legionella or for pneumococcus. We can use automated monitoring of culture results to alert us as quickly as possible to when a culture becomes positive, so we can at least address to make sure we're giving the right antibiotic. We can use matrix-assisted laser desorption ionization with time of flight to help identify and come up with antibiotic sensitivity testing. We can use PNA FISH technique with fluorescent in situ hybridization, PCR technology, or use syndrome targeting to help us identify those patients who are likely to have a specific type of infection. Here we see some of the new capabilities that bring the time down from 24 to 48 hours of doing cultures in the lab and getting growth and then putting on the disc to determine sensitivity, where now we can bring the time down maybe to 5 to 24 hours to even less than an hour on some of these assays to tell us what is going on. So we've made a great leap going from some of the old methods with looking at cultures to some of the newer MALDI-TOF mass spectrometry, where you can take positive blood cultures and in less than 2 hours, you'll be able to tell what the organism is and maybe what the sensitivity is. Here's the MALDI-TOF mass spectroscopy, which can now look at 193 organisms, gram-positive, gram-negative, anaerobes, and yeast to tell you what is the causative organism. Here's the Bruker Microflex, which can give 40 gram-negative bacteria with a rapid detection. We talked about the PNA FISH, which can be beneficial in helping identify those with Staph aureus, coagulase negative staphylococci, Enterococcus. We can look at various Candida, albicans, glabrata, tropicalis, cruzii, parasolopsilus to help you with subsequent confirmation of infection and help influence your antibiotic decisions. The Gene Expert is available to rapidly identify those with MRSA, MSSA to help again with antibiotic decision. We now have the BioFire film array blood culture. They also have throat swabs and the like to help rapidly identify patients with gram-negative bacteria, gram-positive bacteria, fungi, and even come up with antibiotic resistance panels to alert you that you may have a pathogen that's not going to respond to the antibiotic that you may have chosen. And then the Verigene Nanosphere blood culture also helps give us a rapid identification of a variety of bacteria and also various resistance markers to help with antibiotic decision-making to ensure that we are giving the correct antibiotic strategy. So to reemphasize, we are on the stopwatch. Once we identify a patient has potential sepsis and we've localized where we think the site of infection or the source of infection is, we have minutes to an hour to get our antibiotics in, make our antibiotic decision, decide about source control in order to improve outcome of our patients. So knowing what we're dealing with early will help us not only with eventual outcome of our patients, but a lot of us deal with infection control issues that we'd like to implement as soon as possible. We may be in a situation where we want to cohort like patients in order to minimize spread of some of these resistant organisms. And if we can better tailor our antibiotics and decide if we need to use adjunctive therapy or additional aspects of source control, that should all result in improved outcome for our patients. In addition, finding that maybe we don't come up with something positive may actually help move us to additional workup or testing to help move us to get control or improve our patient's outcome in a more rapid fashion. And what we really hope will be the outcome is to have early tailoring and de-escalation of therapy, because that is good antibiotic stewardship. That's the way that we are going to be able to balance our ability to improve our patients and help them get the outcome we desire and avoid participating in more antibiotic resistance or antibiotic-associated complications. So we want to start our antibiotic, broad spectrum, get it as soon as possible, tailored to the site of infection, likely organism, knowing our antibiogram. As we get data on culture and sensitivity, tailor. As we get improvement, de-escalate. And we want to treat for the appropriate length of time and don't over-treat, because we don't want to add to this problem of antibiotic resistance or producing antibiotic-associated complications. Finally, let's talk about where we are with our ability to treat the patient with severe sepsis and septic shock. Fortunately, the mortality rate is moving down from the 20 to 50% that it was a decade ago, and moving down to a more reasonable type level, but it still is dependent on a number of variables, which I will share with you in just a minute. One additional problem: survivors of sepsis have been shown to have an increased mortality for the next 8 years. They are also associated with having decreased cognitive abilities and an increase in health-related quality of life issues. So just getting through sepsis only begins the second phase of challenges of trying to return back to the life that this patient once lived. Now, fortunately, we see that in looking at the National Information Systems database of over 161 million hospital admissions in the U.S. over these 4 years from 2003 to 2007, sepsis was diagnosed 2.98% of the time, which was a 71% increase in the number of cases of severe sepsis over that period of time. Unfortunately, the estimate for hospital costs that Derek Angus had put forward, which was $15.4 billion, was vastly low. Turned out that the cost of caring for these septic patients was $24.3 billion. The number of deaths increased even though the in-hospital mortality rate decreased, and that's related to the dramatic increase in number of patients with severe sepsis and septic shock. I'll also call your attention to the fact that a lot of our people aren't dying in the hospital, but are being discharged to skilled nursing facilities, which not only increases potential costs, but also that shifts the area that there may be mortality from hospital mortality to the skilled nursing facility. Now, the folks in Australia and New Zealand over 12 years had put together bundles of care and other attempts to improve their management of patients with severe sepsis and septic shock. When they did a retrospective review of over 100,000 adult septic patients, they found that mortality had decreased from that 35% to about 20%. And they also had an increased rate of home discharges, which was a little bit different than we've seen here in the U.S. So we have a challenge ahead of us. The ability to early recognize, diagnose, and begin treatment of the patients with severe sepsis is the gauntlet ahead of us. We see that there are many more patients who are at risk. We have a lot of potential to have to make antibiotic decisions that are going to be a little bit difficult because we don't know what antibiotic resistance patterns are in our community. So we need to think about the exciting potential for biomarkers alone or in combination with our clinical acumen and maybe some of these rapid detection assays to help us early on identify populations at risk, and identify the population likely to benefit from various therapeutic interventions, guide appropriate use and duration of antibiotic therapy, and give us prognostic information to let us know, are we indeed on the right track with our current treatment? We know that these biomarkers may serve as entry criteria or surrogate endpoints for clinical trials to help us better identify efficacy of new treatments that may be coming down the pike. We've seen that the rapid diagnosis of infection has the potential to improve outcome and decrease bacterial resistance by helping us do better antibiotic stewardship. But with all of this, I don't think we have any substitute for combining these biomarkers and these new technologies with critical thinking and careful clinical evaluation to help us better take care of our patients with severe sepsis and septic shock. With that, let me conclude my presentation.
I'm Dr. Bork. I'd like to thank you for an excellent presentation today. And I'd also like to thank our sponsor, Biomarkers, for presenting such valuable information to our audience. And thank you to all of our audience for joining us. We hope you will come back and partake of other webinars here. Again, thanks so much. And with this, I will end the broadcast. Thank you, Dr. Bork.
Thank you.